No, a P2Y12 antagonist that is not a prodrug, and therefore you don't have to worry about the drug interaction. It's ticagrelor. You recognize grel again on it down, but this one, ticagrelor, is ready as is, so no issue. Another one that's been used is a prodrug, prasugrel, but it doesn't use 2C19, so at least it's not bothered by the proton pump inhibitor. Well, I have one note to give you here, is that H2 blockers also can inhibit P450. General inhibition, so 3A4, 2D6, 1A2 as the main P450, but it's only which H2 blocker? There's only one H2 blocker, that's why we don't use it, but it's a prototype. What would be the H2 blocker to worry about? Zahir, well done. Cimetidine. Huh? Cimetidine. And cimetidine, up. An H2 blocker also can inhibit P450, but there it's even more broadly inhibiting than proton pump inhibitor, particularly when you block 3A4, you then call the general inhibitor because virtually all the drugs get metabolized by 3A4. So be careful there. What's neat is that this is not the case for the other tidines. And the other tidines include, of course, famotidine, nizatidine, and what is the other one? Ranitidine. There we go, huh? Let's see. Did we really look at every drug we could use in peptic ulcer disease? We have anti-H2, we have the omeprazole, all the antacid, the antibiotic, the misoprostol. So we left with one drug, guys. It's a prodrug, but it's a prodrug that becomes a sticky gel only if you don't take an antacid. It needs a low pH to be activated. So do you know which drug this is? And then you've gone around the entire arsenal of drugs we use in peptic ulcer diseases. Sharon, tell us. Sucralfate, you are totally correct. There we go. And then finally, we'll say sucralfate, that's a prodrug that becomes a sticky gel, only providing there's low pH. And then the idea is to coat the ulcer crater. So it's basically a cytoprotective. But it doesn't do anything. Of course, here your danger is acid. Cancel the activation. So this one, it's the pH. That's the issue. And there we go. Hopefully that takes care of drugs used for peptic ulcer disease, dyspepsia type of setting. Any questions on that? Let me save it. Let's see, Zahir. You're typing. Will omeprazole reduce the activation of sucralfate since it decreases the pH? Yep. Antacids in general, as I have. So anything that would raise the pH is going to interfere with sucralfate. That's why when you think of it, I wonder why we always review it in med school, because I wonder who in their right mind really uses sucralfate. Bismuth subsalicylate, it works as is, as a sticky gel, so it doesn't depend on a low pH. And you see that this is the one we added to metronidazole and tetracycline in the process of fighting H. pylori. So, all right. Tell me a little bit about Gerd. You're welcome. I don't want to make a question. I just want you to tell me about first the number one cause of esophageal cancer in the US. What is it? That's the precursor lesion, Zaire. It's actually, therefore, Gerd causing esophagitis and, importantly, therefore, causing an important metaplasia. Tell me about the metaplasia. From squamous to columnar, Brian, you are totally right. I'm sure Annan, Haley, you're about to type the same thing, right? So basically from squamous to columnar, so what we call a metaplasia. And the columnar is basically intestinal mucus producing cells in pretty much the lower third of the esophagus. Now, right now, it's a metaplasia, it's not cancer. So then it would have to acquire some dysplastic characteristic and then become an adenocarcinoma of the esophagus. Now, contrast. Alcohol, smoking. Okay. Damage from caustic agent like lye, for instance. You know, maybe someone who tried to actually commit suicide by ingesting something to unclog a sink or a toilet like Drano, and then unfortunately they burn their esophagus and survive. Well, then down the road they develop cancer. Tell me about a middle-aged female with iron deficiency anemia and some dysphagia because of webs in the esophagus. What do you call that? Plummer-Vinson syndrome, Sam. Absolutely. We'll put Plummer-Vinson syndrome. These are as many causes that would increase the risk of squamous cancer of the esophagus. Is that okay? So that's always an important story. So because for us, our main cause of esophageal cancer is subsequent to Gerd, well, how do we treat Gerd? It's the easiest thing. What's your number one treatment for Gerd? I'm going to say, see above, number one treatment are the proton pump inhibitors. So proton pump inhibitors are used both for peptic ulcer disease and for gastroesophageal reflux disease. They're the most effective in the long run. of course, in that story. So that's obviously pretty good right there. Now, tell me, issues of dysmotility in the esophagus. Which portion of the esophagus is striated skeletal muscle, regular skeletal muscle, not smooth muscle? Just checking. Okay, third where? Ah, okay, Anand. The upper third, the beginning portion, essentially. Whereas the lower third, if you want, or the lower portion, we should say, is smooth muscle. So, anyone tell me which portion of the esophagus would be responsible for dysphagia in a patient with myasthenia gravis? And if you're not sure, myasthenia is a patient who has autoantibodies against the nicotinic acetylcholine receptor that you find at the end plate junction. So, Zahir, you're going for the upper portion. Naili, tell me. Sam, you want the lower portion? Let's see, Naili. You want the lower two? Actually, if it's myasthenia, it's skeletal muscle as a pathology. So Zahir is correct. Is that okay? Contrast, if you had scleroderma and you have sclerosis and you get your esophageal dysmotility, then it would be the smooth muscle type of issue. You okay for dysphasias? And normally dysphagia, if it's only too solid, then it's probably not a muscle issue, right? If it's only too solid, generally it's an obstruction, maybe a web type of issue. But when you start seeing dysphagia to both solids and eventually liquid, then that's often a sign of neuromuscular type of diseases. Well, I just thought I would ask you this in passing without making a case, but I always thought that was quite interesting also to pull out for the exam. Well, I'm going to leave that section and build another type of question. Unless you have any special question on this? No? You all clear?